Hello, I'm Shannon Moreno, CLC specialist with Texas System of Care. This is our fourth episode of our podcast series on working with youth with intellectual and developmental disabilities. We continue our conversation with Michelle Garcia, clinical psychologist at Michelle Garcia, Psy.D and Associates in the Woodlands, Texas. Kind of along the same lines of some systemic issues that may come up, do you see with this population some issues that affect the population perhaps a little bit more than folks who don't have IDD? So things like for receiving other services, higher waiting lists, or not having as many services in communities that can meet the needs of individuals with IDD, other considerations like that that may certainly be a factor for anyone, but may impact this population a little bit more?
Absolutely. So, there's so many areas where there are more barriers. So you mentioned waiting lists. Unfortunately, there is a long wait for some of the services that can help these individuals for the rest of their lives. So there's a program called the waiver, and that has an extensive wait to be able to receive those services. And so in the meantime, for individuals with disabilities, they're in school. They're able to be in school until the age of 22. But after that, being able to access supports if the person does not have that waiver service, there's a significant lack of resources. Day programs are available, but they cost money, and sometimes individuals or families don't have that money to be able to pay for it. So in the meantime, there's limited resources in schools having access to services. I mean, within the last few years, there was a reduction, intentional reduction of people in special education or receiving those services due to some educational programming that went on. And so they are trying to reduce numbers of people in special education, which means that individuals are not always getting diagnosed with disabilities at the younger ages that they need to be in order to access services. Also, I find that at the university level and in doctoral school and graduate school, there's not as much focus on providing services for people with disabilities. So what that means is there are less professionals, less medical professionals, less nursing staff, less clinical staff who are educated to provide these services. And so, for example, there was an insurance change for people with disabilities in a rural town. And in that rural town, there was only one psychiatrist for the entire population of people with disabilities. And when that insurance changed, that psychiatrist was no longer in network. And so all of those individuals had to find another psychiatrist. And actually, even though Houston is one of the largest cities in the United States, we actually have a huge lack of psychiatric resources for people with disabilities, or at least psychiatrists who've been trained and who actively are taking patients who have disabilities. Mm-hmm. And so from medical to educational to social to just daily programming, for people without disabilities, oftentimes after school, they either go to college or go to trade school or go into the workforce. And so for individuals, let's say, who can't verbalize and who are not able to enter the workforce and not able to enter college or trade school, what do you do if you don't have these state-funded services? And again, like I said, these state-funded services, there's a good 10-plus year wait for some of those services. So it's just, there's certainly a lack of resources. And so one of the things that our team really pushes and tries to speak about as much as we can is because there's those barriers, we need to do something about it. But there's not a lot of income to do that because there's not much funding to do that. However, there are so many organizations out there all trying to do the same things. And so what we've encouraged agencies to do is to work together. Mm-hmm. If just 3 organizations work together who, are within the same circle of town, so they're all 3 in Katy, or they're all 3 in Sugar Land, or they're all 3 in the Woodlands, And there are many organizations in the same town. If those three organizations work together and said, hey, every Friday, everybody's going to come here to our program and we're going to put on a party. And, another organization said, great, on Wednesdays, we'll do exercise together at my place. And another organization said, hey, how about, once a month we put on a dance or something like that. If the organizations work together and kind of pooled their funding that they're using anyway for servicing those individuals during the day, what a difference that would be. I mean, these individuals would at least have increased socialization and other individuals that they're getting together with and other resources and, other things like that. Also just looking around the general community. Sometimes your locally owned, quote unquote, mom and pop kind of places are open to individuals coming in and volunteering or being a part of initiatives, things like that. So that's something I used to do when I worked in Lafayette is I would walk around the city and go into art galleries and say, hey, I've got somebody diagnosed with a disability who loves to do art. Is there any way that this person could put art at your art gallery? And sure enough, I was able to find one that not only did they say yes, but they were willing to offer some art classes for that person. So sometimes it just takes that creativity. We've also talked about within the day doing additional social recreational things that don't cost a lot of money. I mean, you can put together different art projects on low funding, such as we did one where you take shaving cream and food coloring, and you can even add glue and create something more permanent where the person just has the sensory experience of moving around the shaving cream into various shapes and putting food coloring in it and making something. And, just there's so many different things that can be done with low funds. But again, it takes that passion and creativity. And I think sometimes, unfortunately, when you reduce funding, you also then reduce encouraging people to come into the IDD field who have passion and creativity or who are still energetic as they're burning out on trying to do more with less money. And so you have all this turnover and then you're having to deal with turnover. So how can you even think about putting on a dance if you can't keep staff there on a day-to-day basis? So, I mean, I think there's barriers. There are solutions, that I think are there, but it's finding those passionate, energetic, creative people to kind of come together and pool their resources.
Yeah. And I think another issue as far as, some of these systemic things that we've kind of touched on a little bit before, but I'm wondering if maybe you can expand on a little bit, is this issue of kind of a lack of professionals to refer clients to, because it's not just necessarily with this population as easy as, you were talking about within the Houston area. It's not just a question of if there are psychiatrists, but are there psychiatrists who know how to work effectively with this population? And that's with pretty much anything. So it's not just is there a primary care physician who's in network for this family's insurance, if they have insurance, but is there a primary care physician who can work with folks with IDD and anything else? And then when you think about with youth who might have multi-systemic involvement, so if a family is engaged with CPS or with the juvenile justice system, certainly they're going to be engaged with the educational system. Again, it's an issue of at an interdisciplinary level, are these different professionals going to know how to work with this family and know how to work with this youth? Can you expand at all on that idea of when you need to refer clients to some service or another, or you recommend engagement with a particular profession? What's the difficulty there? How do you determine if you can refer them to someone who's going to be effective?
So you touched on a couple of different things. One is trying to find specialists in different areas who have the training and experience. I think that is something we really need to go back to the universities and do more advocating of students being better trained. and educated on work with this population, because I find even for myself, as a practicum site for clinicians, we go out and talk to the students, and invariably the students who come to us are coming to us because they heard from their professors that we have a comprehensive site or we have a good site, but they're not really interested in working with our population of people with disabilities. Or there may be other students in the class who hear us say that, this is what we do, and immediately they're not really sure what that means. And what they envision is going into a traditional private practice where they're going to see clients who are able to verbalize and who are intelligent and goal-directed and things like that. And unfortunately, that's not necessarily the real world of what everybody's going to be able to do. And I think for physicians as well, they go into their specialty, whether it's neurology or cardiology or what have you, and the focus is there. It obviously in medicine, there's a big need for it to be based on biology. But at the same time, are we doing a good job of educating the physicians on, okay, this is for people who have these typically developing individuals, but what about for individuals who are complex, who have intellectual developmental disabilities, who have autism, who have Down syndrome? What do we do then? And do physicians, are they interested in doing more complex, or are they looking for, primarily just surgery or just this or just that? And so, I think we need to do more advocating at the university level of drumming up interest and letting people know how rewarding and wonderful it is to work with people with disabilities, because it absolutely is. And so it starts there to be able to have the resources in the community. But then beyond that, so, when we want to make a referral, a lot of that has to do with networking. So, I've done a good bit of networking to try to find the pockets of primary care physicians, psychiatrists, neurologists, different specialties I can refer individuals to who I know, one, have experience and training, and two, are willing to work with a multidisciplinary team that this person has in their life, that's willing to listen to the psychologist writing the behavior plan, or willing to listen to the service coordinator who's known the person for 10 years. And so finding that combination is extremely challenging. There are some individuals out there. There are some excellent physicians I've met with out there. There are some excellent educators out there, getting the schools as well to provide training for their teachers. I have one student I'm working with who's diagnosed with Asperger's, and a lot of his behaviors at school have to do with the way that he sees things, the way he sees his environment, the way he interprets interactions. And so when I went to his art meeting, that was something I really pushed with the school is, how well trained are all the teachers that deal with this individual on working with somebody with an autism spectrum disorder, and how the person sees things and how to talk to them so that the person can understand and de-escalate the situation. And they, acknowledge that type of specialty training is something the teachers are offered but not required. And so we talked about getting it added to this person's plan. And so, again, I think it's about trying to find the ones who work well, but also advocating for more young up-and-coming students to understand why it's so critical and why it's so wonderful to work in this field, and then encouraging the universities to provide that training.
And it sounds like even for students who don't necessarily choose to focus on this population specifically, in general, if you are going into a helping profession of any kind, you're going to come across folks with IDD at one point or another. And so even if you don't plan to focus specifically, again, on serving this population, to just have pretty much no competency, no knowledge base whatsoever, it's just sad. I don't know what other word to put to it. But, we may think, for any population, whether we're talking about IDD or any other specific population that we're focusing on, we can say, that's only, X percent of the total population in Texas, or that's only roughly X percent of the total population in my local community. Well, that may be the case, but that doesn't mean that those individuals are not deserving of good care. And for those individuals who make up what could be perceived as a small percent of that population, this issue or concern or this component of who they are as an individual is a large percent of their life, or potentially has a large impact in their life and a large impact on their care. So I think that that's a wonderful suggestion to increase, even at the university level, competence with the population. Absolutely.
I hope you enjoyed today's CLC podcast. If you have any questions on how to bring CLC initiatives into your local system of care community, please feel free to email us at info@txsystemofcare.org.